Okay. This is the anterior view of the patient. You see on the CT scan of the anatomy of the patient, you know everything about this patient because Giampiero showed you which is the anatomy. This is the guide. And you see here, there is some part that to be removed from the guide, checking some resin interferences here have to be removed because there is some stereolithographic artifacts introduced by the production of the guide and not directly from our planning. We had to check of this situation and checking also which is the part that you can touch of the guide, the resin part, but not the metallic cylinder. So if you try in the mouth the guide, sorry for the head, because we need a direct visualization if there is some pressure between the metallic sleeve and the gum, and you know that you have not to touch the metallic part of the guide, but we think that we have removed all because we check digitally with the finger the stability of the guide. There is some movement in the back, and maybe you have some interferences in this anterior part. And pressing with fingers we can also see which is the red part, and with the bar without water, like a little burning because we reduce the bleeding, we can remove the interferences of direct in the mouth of the patient and try again. And all those steps Giampiero made before the surgery, and you can check also before the surgery playing with the models. You can check. You can avoid the water. We can reduce the bleeding because we have a better visualization of the situation. Checking again if you have a right, and we see a little reduce of movement. So this is a good way to show you how to manage some reducement of the gum indirectly very close to the surgery. But now the sensation is better, and we decide to start with surgery. So I will show you before. I say before, you have to handle the surgical silicone index to the guide, because we love to enter together. In all the two devices together is better. So we can ask now to close the mouth to the patient, and now is the moment, the key point. There is my hand on the chin. We ask the patient to stay very, very firm. And now we are using the 1.5 millimeter drill for the anchor pin. You can avoid, it's mandatory to avoid any movement in this part of the surgery. And this is the fixation of the buccal pin. Okay. There is a stop here. We can remove the silicone index now.
Apra.
Ok, si muove tutto. No.
Adesso aspiriamo bene, bravissimo. Aspirare. Okay.
Now we are approaching to. Dammi uno strumento, qualcosa che blocca da sinistra, io da destra. I take and very
Prolunga.
we have to show you how to handle the stabilization of the buckle pin. Allora devi aspirare lei, sempre il solito momento, sempre il solito problema. With two instruments in the back or two fingers, we have to stay very firm in the back while we are driving the drill on the palatal side. Okay, we prepare the osteotomy both, and now we are placing the two. Vero lungo.
Andiamo per le parti.
Lo so.
Allora, però lungo. Uno lungo.
No, uno lascialo, questo lascialo.
Lungo. Un quarto più lungo.
Now we are checking some interferences with the tools because sometimes they happen with the crossing palatal pin, and we can avoid this. So in this moment we are obliged to use a longer pin to avoid interferences between the crossing pin, because sometimes, because we love to have this palatal stabilization, we have also to check the interferences. So, starting with the protocol that we start to show you before. Before starting, we need a soft tissue punch, circular tissue punch here. We drive this drill through and through because we have to be sure to have cut it in the right way, the gingiva. So we have to check if this drill is quite new, because when you touch the bone after many surgery, you lose the cutting capacity of this drill.
Si vede?
No, cambia la mano.
Un po' più sotto. Se vuoi vengo un po' più sotto. Se non ti dà fastidio. Sì, io non ti dà fastidio.
Maybe now it's better to show you. We drive the punching again to be sure to have cutted the gingiva. Now, second step, counterbore drill. We use the counterbore drill. Now I ask to Giampiero to show you 1 minute the shape of this drill. Non ti preoccupare. Faglielo vedere un attimo com'è. Sorry, this is the counterbore drill. We have a part here to cut the first part of the bone, and we have a stop here. So we have to be sure to drive this drill till we touch with the stop the metallic cylinder. Control the vibration, please, of this drill. And you see we perforate through and through, allowing us to remove the soft tissue. You see the soft tissue jump now from the metallic sleeve. And anytime we have a deep control of this movement, okay. You see here all the soft tissue jumping through the guide. Thanks to, this is the soft tissue here, you see. Sorry.
Spira da
Lo so, è andato via. Avete roturato.
Bravissima, aspiriamo noi.
Ok. This is still the counterable drill because we have to be sure that we have to remove all the soft tissue and that we break some cortical bone, above all in the part of the knife edge when we have the fusion of the cortical part of the bone. We have to destroy any coronal interferences that allow us, our implants to go to the bone. So, let's start with the protocol. This is the reductor for the 2 mm drill. And this is the handpiece to handle better the movement. So we have a control of the position and we change. Look at this movement now. Now I ask Giampiero how to enter to the mouth of the patient. Sometimes it's better to... Okay. We are trying to understand which is the best access for this reductor to show you better the movement. So there's no problem here. Okay, everything's okay. But there is another check, important to show you. There is sometimes we have some resin interferences for the reductor. So the deep control of each step allow us and teach us which is the control also during the surgery. Trying the reductor, because the reductor had to be enter perfectly. We have a perfect fitting. Perfect fitting between the reductor of the drill and of the mouth. Many times it's better to hold the drill with the reductor and enter into the mouth of the patient with both. Okay, look at this movement here. As I said before, the 2 mm drill is the probe of the local density. So, if you see, and we try to engage.
Very bad bone.
But it's a very bad quality of the bone. You see the drills go very easy into the bone. Simple surgery, but not so good for immediate loading. That's the reason maybe that we choose active implants here. To guide the drill to enter some solution. Insomma.
Very good cortical, very bad
you feel with this drill a very good cortical bone at the beginning, but a poor density on the medullary space, as we expected also from the planning. Okay. Che diametro devi mettere?
Faccio una passata tra i due? Beh, meglio, no?
Decidi, io lo dico. Puoi dare
3 mm.
Ok.
No, però perdo la forma. Dammi la 2832. Quella nuova.
Now,
È la nuova guida.
as we stopped on the movie before the surgery, first step 2 mm drills and 2.8. Now we are approaching to place the first implant. Then, this is the 3.2 mm drill. We have the marker at 7. Now we have 10.
Only 7 mm.
We under a little bit under preparing in length. We are still in time to drive the drill deeper. And we try to... And we use the implants itself like a probe if we have done the right preparation. So, you are, at this moment, you are still in time to drive. If you drive all the drills, all the 3.4, 3.8, and so on, you never go back. So if you are able to, okay, you can choose to try to insert the first implant to check what is the situation. If you feel too much insertion torque, you have to stop, remove the implants, and drive all the drill. This is the active implant that we selected, and we start apra grande grande. We ask the patient to open the mouth and see the movement now. We insert the implants in reverse section. You know this device is in reverse. Reverse section till the implant mouth engage the metallic cylinder. Then, at this moment, we are fully guided and we can go down with the implant. And the implant go down very easily. The important is not to touch, not to reach immediately the right depth. Here, there is some space. Don't touch, please. At the first time, the guide with the implant mouth, because it means that you insert deviation. If you touch the guide now, you deviate the implant. So there is a final adjustment of all these implants. So we can drive the 3.2 millimeters here, low quality of bone. We can avoid our masterpiece that is screw tapping here, because there is no so good bone quality. And so 2 millimeter, 2.8, 3.2, first implant. If this implant is too much high insertion torque, you are still in time to stop, remove the implants, and drive the wider drill. Okay, this is how to handle the implant mount onto the implant. You see, you have the stop here. It's an hexagon if you want to orient the connection, but anyway, the important is that we learn from the first osteotomy which is the right protocol for the adjacent site. And we learned that the last one is 3.2 millimeter drills and implant.
Apra, signora, apra.
You have to set the motor in reverse section because you are free. The implant at the beginning is not really guided. You are freedom. So don't start in the right position with the cutting properties of the implant. And we set the motor at 20 newtons on insertion torque, very, very low. We can jump to okay, and we see that the implant go down because it's not so good quality. If you so that doesn't mean that we choose the right implant. 3.2 and implants. No one of these implant mount, the stop of the implant mount, touch the guide. You have to leave space in between, here and here. This is our protocol. We will reach the right depth only at the end of the surgery, because if you insert many implants, you insert some tension in the system. Other active implants here, the same movement. We are free here now. Look at this movement now. You enter in reverse section. I want to show you the hand of Giampiero. When you are fully guided, you can leave the hand from the device. You are fully guided, let you drive from the system, and don't use not so much force in this kind of surgery. So the secret is entering into the osteotomy with reverse section, because the implant doesn't cut so much. When we are guided, we can turn in the right rotation and never touch with the implant mount the guide. That means deviation, displacement of the guide, a little bit displacement. The important in this moment that we transfer all the implant parallel to each other like we do in the software. We are free now. We engage the osteotomy in reverse section. We feel a little jump. We will see on Saturday during the hands-on training, we see a little jump of the implants when the implants engage the osteotomy. You will see by your hand. So, the secret is the first to drill in all the sites and place the first implant, that is the most important implants. Then we have to dedicate attention to transfer to the adjacent site all the deviations. So, first implant, last drills and implant, last drills and implant, last drills and implant, without touching the guide with the implant mount. Many systems we have no stops here, and so we are more free to go down. But in the system that we have some stop on the implant mount, it's not so important, and you have not to touch the guide with the stop. Same movement. Till we have freedom in the system, engage the osteotomy in reverse section. Then when the implant cut by itself, you have to only to control how this is the situation. If you have too much torque, maybe we have a mandible next day, we will see another movement, because if a yes, we don't use any screw top or other things that we will see because of
very low density.
Non è l'ultima presa. We avoid to drive the last drill here because we have very type 4 bone here. We have fat, it's not bone. You are still in time to drive the drill, because if you feel hyper-torquing, you have to stop and unscrew the implant. The meaning that the implant itself, we try to insert the implant, but the implant says, too much torque, doctor. So we stop, remove the implants, and are still in time to drive the drill. We can undersize in length, maybe. Apra grande, signora. Ok. Un anno libero? 3.7.
Sì, 3.5.
Eh?
3.5.
Okay. You have to remember that these implants, they have self-cutting properties, and this always an undersize of the otomy, because this is 3.2 and the implant is 3.5. So try again with the implant, checking if the implant go down in an easier way. Engage, but anytime engage the osteotomy in reverse section and turn the rotation only when you engage the metallic cylinder with the implant mount. But don't touch anytime. If you feel over torquing, unscrew the implant completely. Or you can try to unscrew and screw again the implant, acting the implant like a screw top. So, look at this first movement. We insert tension in the system, so we unscrew all the implant. That means release tension, because we have to avoid deviation. Our goal is to place the prosthesis, not to place the implant. After this movement, Giampiero released all the tension. We set the motor at 30 Newton of insertion torque. So we have to rinse perfectly, because we have to have a best direct visualization of the right depth of the implant. So the philosophy is at the beginning, we have not to touch the guide, and there is a final adaptation one by one, very, very careful. Okay. We have, you know that the implant touch the guide at the maximum torque of 30 newtons, not so much. And it is not so real, because we have a friction between the implant mount and the metallic cylinder. So maybe we have the real lower insertion torque. So, but this is the final situation. This is the final situation. You see, all the concept is chemical that we show you, and we repeat all those steps. It's not so standard in this case, because we have to manage the low quality of bone, an atrophic maxilla. So now we approaching to remove the implant now, and
questo è tutto storto, con il sensore che è deviato, completamente deviato.
And we had to, in the low density bone, another mistakes at the beginning was to unscrew the implant. So we had to take, and look at this implant mount here. That is very easy to have to be sure that we unscrew the fixation screw. But this implant mount from an novel biker is very, very smart, because you can unscrew, but you cannot lose this fixation screw into the mouth of the patient. And the assistant, that it's me, that we have to control that all the screw fixation screw is completely unscrewed. You see with the pinset here, the movement. Okay, now we can leave the implant mount. So, if you see, the implant mount leave very easy the implant. That means that we have no tension. If you see this movement, it's very easy to remove. There is so much, if you feel so much compression, like in this place, because we have harder bone here, so there is maybe a little deviation of the implant, but sometimes it's only the friction between the internal connection of the components, between the implant mount and the implant itself. So a little bit circular movement to disengage the implant mount, and then when you have a good hand feeling, you can remove the implant mount like this. Maybe you have some friction here, you know, but we know that because we avoid to use all our steps like the screw tapping because we have to manage a soft bone here. And if you introduce some variables, we pay the price with some little deviation. Cascato il cacciavite.
Questo è quello di metallo, ma questo è quello di metallo.
Now we're taking all the implant planning, and why we use, despite the cantilevers and other compromise, because a trophic patient is still every day a compromise between soft bone, immediate loading, cantilevers, and so on. But the important is to show you the respect of the planning and how this surgical handling allow us to help us to reach the same position.
Possibilità di cambiare accedito in posizione. Per favore datemi supporto.
This is the prosthesis. You see the prosthesis now, and now we are approaching to fitting. There is some possibility to engage the prosthesis. There is a metal shouldered bar inside. You know, you have the rigid system now. So we approach with the finger. We press a little bit to force the releasancy of the to check. And we try by manual screwdriver. If you are able to engage some screw, we feel some engagement. If you feel some manual engagement with the manual screwdriver, it's the first good sensation. You can press a little bit because we have to force. Sometimes we have some resiliences of the mucosa. Then, after checking by manual sensation, we change with the motor device. We use the screwdriver. We set the device, the motor device at 20 newtons because we know that this type of torque-tight screw can be tightened at 35 newtons or more. But we start with we place the implants with a low torque because we have not to break anything. So we try with finger. And then we start with the motor. First,
Apra, signora.
apra. 25 Newton.
Non vedo. 25.
Okay, we see the beat of the motor that we reach 20 Newton. One by one, like the implant, after the manual engagement. Forse c'è bisogno di una prolunga.
Mi dà una cacciata giusta.
Tutta la prolunga del motore.
Dammi una cacciata giusta.
We need a longer screwdriver because we have interferences with the prosthesis. Okay, 20 Newton. Vuole stare indietro, devi stare indietro, così?
35. No, lui che sennò 30.
30.
Ah, stai attento con la testa, per ora sta guardando. Ok.
Non vedi buchi.
Now we are dry to 30 Newton of insertion. It's a gradual augmentation of the level of the insertion torque for the tightening of the screw. C'è la testa davanti alla luce, sì. Then we reach 35.
Il motore,
We are still to
il pedale.
secure the prosthesis at 35, but
Delicatamente, signora, chiuda.
there is the first check
Chiuda,
for
chiuda,
the occlusal
Chiuda.
check. There is some
Apra.
contact on the posterior, but we know from the models.
No, allora.
But also, it's the first time that the patient bites of the new denture.
Ok, chiuda.
And if you see here, now the situation is really changed.
21.
Then, after checking by manual sensation, we change with the motor device. We use the screwdriver. We set the device, the motor device at 20 newtons because we know that this type of torque tight screw can be tightened at 35 newtons or more. But we start with we place the implants with a low torque because we have not to break anything. So we try with finger.
Zoom un po' più largo, si vede troppo, è più largo.
And then
Si vede il naso.
we start with the motor. First,
Apra, signora.
apra. 25 Newton.
Non vedo. 25.
Okay, we see the beat of the motor that we reach 20 Newton. One by one, like the implant, after the manual engagement. Forse c'è bisogno di una prolunga.
Mi dà una cacciata giusta.
Tutta la prolunga del motore.
Dammi una cacciata giusta.
We need a longer screwdriver because we have interferences with the prosthesis. Okay, 20 Newton.
Sì, scusa, dove?
Vuole stare indietro, devi stare indietro, così?
35. No, lui che sennò 30.
30.
Ah, stai attento con la testa, per ora sta guardando.
Ok.
Ok.
Non vedi buchi.
Now we are dry to 30 Newton of insertion. It's a gradual augmentation of the level of the insertion torque for the tightening of the screw. C'è la testa davanti alla luce, sì. Then we reach 35.
Il motore,
We are still to
il pedale.
secure the prosthesis at 35, but
Delicatamente, signora, chiuda.
there is the first check
Chiuda,
for
chiuda,
the occlusal
Chiuda.
check. There is some
Apra.
contact on the posterior, but we know from the models.
No, allora.
But also, it's the first time that the patient bites of the new denture.
Ok, chiuda.
And if you see here, now the situation is really changed.
Cambiami.
And
Non vedo.
now we try to move the patient, maybe, to show you better the occlusal result at the first sensation because now we are approaching to the next step. There is the radiographic confirmation of the fitting of this prosthesis onto the implant before the final tightening. After the control of this fitting by X-ray, we can jump to the final torque tightening of the screw, that is 35 or more. But this is our pleasure to show you the occlusor, the very first time that okay, you see the occlusion of the patient, and this is a very, very good result because you have a very good sensation of the. Sorry, I was laughing with Giampiero because a very, very good sensation. Then you have to jump to look at the X-ray. Look at the X-ray. Posso levare il microfono, vero? Now we are for checking by the X-ray, and maybe I can stop my microphone now and I come to you.